Hello, my name is Esther Lisinge. This is my video on patient perspective for DMPU 700/HP1. It is about respect for patient preferences and shared decision making. Before this current era in healthcare, caring and compassion were once treasured proficiencies needed for clinical practice. Over time, advances in medical science have provided new options that, although often improving outcomes, have inadvertently distanced providers from their patients. The result is a healthcare environment in which patients and their family are often excluded from important discussion and left feeling in the dark about how their problems are being managed and how to navigate the overwhelming array of diagnostics and treatment options available to them. I share the opinion of Erling, Edwards, and Kennersley, 1999, that the second half of the consultation is where decisions are made and future managements agree. However, it is our argument that this part of the clinical interaction has often been neglected by some providers during a time when communication skills development had been focused on uncovering and matching agendas. Erling, Edwards, and Kennersley, 1999, suggested that there are many factors such as increasing access to information and the emphasis on patients. On our patients' autonomy, which have led to the need to give more attention to both the skills and information required to involve patients in the decision-making process. The Institute of Medicine calls for providers to engage patients in making clinical decisions. However, it should be noted that not every patient may want the same level of participation. Patient story. The patient story happened in Africa, which is my late brother-in-law was a 23-year-old male with known sickle cell disease. After a 3-day history of cough, nausea, poor appetite, and chest and hip pain that was unalleviated by ibuprofen or Tylenol, we decided to take him to the hospital. The boy was having an acute painful episode and hemolysis, which are characteristics of the disease. We arrived at the hospital about 6 p.m. We explained to the nurse that my brother-in-law was a sickle cell patient and was having one of those crises. She told us to wait for the physician on call and that there were nothing she could do. The patient was crying, begging the nurse that he needs blood transfusion, as this has always helped him in the past during this type of crisis. The nurse told us that she was not taking any instructions from us. By the time the physician showed up, it was past midnight and the patient was unconscious. The physician requested immediate blood transfusion and oxygen of which the hospital did not have. By the time the caregiver returned with the oxygen from another nearby hospital, the patient was dead. Relevant domain. Patient-centered care requires effective patient and provider partnerships, including shared decision-making among provider, patients, and families. Current research shows that minority and low-income population are more likely to feel disenfranchised in the decision-making process and perceive a lack of respect for their preferences. In addition, studies have found that Patients who make frequent use of complementary or alternative medicine often feel that providers do not respect their decision to use such therapies instead of or in addition to conventional medicine. Ngo Mesda et al. 2006. Providers should work with patients to select treatment that take into account patients' health-related values, weighing available treatment options and patient preferences. The Institute of Medicine encourages providers to respect patients' preferences and promote their active participation in clinical decision-making to the extent that patients feel comfortable and are willing to take part. Patients may participate in their own care in a variety of ways, including having meaningful discussion about their preferences, knowing all of the available options, and making final decisions about treatments. Patients who are active participants in their care have been shown to have improved health outcomes, including lower levels of like blood pressure and blood glucose. Discussions. How well or poorly the situation was handled. Over the years, the patient, that is my brother-in-law, has had time to think about his disease, the effect on his life, and to think about what help he will need in case of crisis. The patient wanted to have some responsibilities in his care, at least the level of providing reliable medical history. After all, it was his life and that the medical professionals were dealing with. The patient and his caregiver gave the idea and rationalized about the patient's illness to the nurse to no avail. The caregiver should have taken the patient to the hospital a little earlier. On the part of the intake nurse, the nurse was not ready to work with the patient to select treatment that take into account patient health-related values, weighing available treatment options and patient preferences. She did not consider the patient's participation in their care was necessary. She, however, did what was part of her duty, that is, calling the physician in case of an emergency. She could not go ahead with the blood transfusion without orders from the physician. However, she failed to stress the degree of urgency to the physician. She lacked the appropriate communication skill. On the on-call physician, the physician did not perform his duty. Over 6 hours after an emergency call before he showed up was unacceptable, but that is the way it goes in Africa. No accountability for such actions. As for the hospital, the institution lacked the basic critical resource to deal with an emergency like this. To have one staff as an on-call physician for such a big establishment was wrong. Now, the reasons why. The respect for patient preference and shared decision-making recommend that providers investigate patient exemplary model of common disease and their health related to values and preferences. For example, why a patient thinks he has sickle cell disease and how he wants to involve his family in treatment decision-making. At the system level, policies should aim to democratize decision-making processes among patients, their families, and their providers. Additionally, policies are needed to provide patients rights to use the alternative therapy or community-based program in addition to conventional medical facilities. Ngo Mesda et al. 2006. Potential proposed solution. Providers and other healthcare organizations should not assume that patients wish to participate in clinical decision-making making, but must assess individual patient preference and tailor care accordingly. The Committee on Quality of Health Care in America, Institute of Medicine, 2001, recognized that some patients may not want to be active participants in their care. At the same time, however, the report encourages physicians to engage patients in clinical decision-making. The recommendations are consistent with ethical principles and with state laws requiring discussions of possible treatment options with patients. Nyfields et al. 1994. Providers should offer patients the opportunity to participate by sharing responsibilities and actively engage patients in the process of making decisions. Providers require accurate information regarding individual patient preference in order to achieve the goal and to avoid inaccurate or biased assumptions about the patient's wishes. Understanding the range and distribution of preference in a population is important to healthcare organizations seeking to tailor patients' education and health promotion programs appropriately. Part of the solution to achieve respect for patients' preference and shared decision-making is by increasing the time available within consultations, improving ways of communicating risk to patients, and acquisition of new communication skills. Ellen Edwards and Kingsley, 1999. This concludes our presentation on patient perspective. Thank you. And these are our references.